Welcome back to Decode Healthcare. I'm Harshal, and we are officially diving into Part 89 of our Explainer series. Today, we're putting on our medical detective hats because we are going to definitively master Section 2 Inpatient Guidelines and the incredibly strict UHDS rules. Now, if you're a medical coder, you already know inpatient coding is just a completely different beast compared to outpatient. Outpatient, you're hunting for a first listed diagnosis, but in the inpatient acute care setting, your entire mission is pinning down that principal diagnosis. Why? Because that single code directly drives the MSDRG payment system. It's the ultimate puzzle, and today we're going to solve it together.
Okay, let's jump right into our zero fluff agenda. First, we're looking at the after-study law, then multiple suspects, symptoms versus diagnoses, contrasting diagnoses, and finally, canceled treatment plans.
Section 1. The after-study law for inpatient admissions.
Our whole investigation starts with the absolute golden rule. Listen to the official UHDS definition of a principal diagnosis. That condition, established after study, to be chiefly responsible for occasioning the admission of the patient to the hospital for care. This right here, this establishes absolute CMS authority from the jump. And the most absolutely critical phrase, the two words you literally have to memorize and live by as an inpatient coder, are after study.
So what does after study actually mean in practice? Well, it's your ultimate investigative tool. When a patient walks through the hospital doors, their admitting diagnosis is often just a symptom. It's an initial guess. The after-study phase is the whole diagnostic workup. We're talking the labs, the MRIs, the EKGs, the continuous monitoring. That whole process is what turns that initial incident into a concrete final conclusion at the time of discharge.
Think of the workflow like this. A patient is admitted in Step 1 for a symptom, let's say severe chest pain. In Step 2, the evidence is studied. The attending physician orders an EKG and cardiac enzyme panels. Finally, by Step 3 at discharge, your principal diagnosis transforms. It goes from a mere symptom of chest pain to a definitive diagnosis of an acute transmural myocardial infarction. You don't code the chest pain anymore because the after-study process revealed the true culprit.
Section 2. Multiple suspects and interrelated conditions.
Now, what happens when your investigation turns up multiple suspects? Because, let's be real, the clinical picture is rarely a perfectly straight line. Under Section 2A, you're going to encounter situations where you have two or more interrelated conditions, like diseases occurring in the exact same organ system. If both of these potentially meet the definition for principal diagnosis, how on earth do you know which one claims that coveted number 1 slot on the claim form?
This is where your power as a coder really kicks in, guided by Sections 2A and 2B. As long as both conditions equally meet the criteria for admission and both receive active therapeutic treatment or diagnostic monitoring during the stay, you have absolute sequencing discretion. You can sequence either condition first. The only time you can't do this is if a specific rule in the alphabetic index or tabular list explicitly tells you otherwise.
Let's put this into perspective with a real-world example. Imagine a patient admitted with chest pain and shortness of breath. The catheterization reveals both Condition A, severe mitral valve stenosis, and Condition B, two-vessel coronary artery disease. Bypass surgery and valve replacement are recommended. Since both Condition A and Condition B equally occasion the admission and both require active treatment, you can legally choose either one for your primary slot. Totally your call.
Section 3. Symptoms versus diagnoses. The classic, smoke versus fire. As a medical detective, you've got to distinguish between the presenting symptoms and the established diagnoses. Section 2A makes the logic crystal clear. If you have an established diagnosis, you do not code the symptom as principal. If the smoke is chest pain, but the fire is an acute myocardial infarction, you only code the fire. If the patient presents with severe flank pain and hematuria, but the definitive diagnosis after study is kidney stones, you code the kidney stones. Never ever code the symptom when the underlying cause is definitively established.
Section 4. Contrasting diagnoses and either-or scenarios.
What if your investigation just hits a wall? Sometimes the medical narrative is stubbornly ambiguous, and you're left with two contrasting conditions that remain completely unresolved at the time of discharge. Section 2D tells us exactly how to handle these comparative either-or situations. And spoiler alert, it's very different from outpatient coding rules.
If a physician writes acute cholecystitis versus acute pancreatitis at discharge, you must code them as if they were both confirmed. That's right. In the outpatient world, you just code the symptoms. But inpatient, you code both of those contrasting diagnoses as established. And once again, as long as they both equally meet the criteria for occasioning the admission, you have the discretion to sequence either one first.
Section 5. Canceled treatment plans and unexpected complications. Okay, here's the ultimate medical record plot twist. How do we navigate a treatment plan that just doesn't happen? Let's say a patient is admitted specifically for a surgical procedure, but before they even make it into the operating room, something goes terribly wrong and the surgery is completely canceled. What happens to your principal diagnosis then?
We look directly to Section 2C for this. If the original treatment plan is not carried out because of an unexpected complication, the condition that occasioned the admission is still your principal diagnosis. Imagine a patient admitted for a scheduled cholecystectomy due to cholelithiasis, but pre-op they suddenly develop a severe arrhythmia. Surgery gets canceled. Believe it or not, the underlying surgical condition, the cholelithiasis, stays firmly in slot number 1. The unexpected arrhythmia simply drops to slot number 2 as a secondary complication. The original reason they walked through the door holds its ground.
So what's the big takeaway from all this? If you make the UHDS after study rule your primary investigative tool, you're going to effortlessly sequence claims in strict compliance with CMS rules. Whether you're dealing with interrelated conditions, contrasting either-or diagnoses, or abruptly canceled surgeries, just stop and ask yourself, what condition after study was chiefly responsible for this admission? Once you master that question, you completely master Section 2.
But wait, the clinical picture doesn't end with just one code, does it? The patient's story is always deeper than just the principal reason they arrived. So what secondary conditions are hiding in the margins of your charts? In Part 90 of our Explainer series, we are going to unravel the mysteries of Section 3 guidelines and UHDDS additional diagnoses rules. Make sure you're subscribed to Decode Healthcare so you don't miss it. See you next time.